indeed, no doubt about it, very, very important. But how about the cardiology? So we all should be aware that the congenital heart disease is indeed a leading cause of infant morbidity across the world. So yes, in some of the countries and all, the data may not be present so much readily available. So we all should be aware that, in fact, nearly 1% of the patient children, especially I would say, like, tend to have congenital heart disease, and in fact, 1 to 2% of these people, the common population, tend to have a developmental anomalies, which is leading to almost 10 times higher prenatal incidence. And that is why the most of the children which are born with congenital heart disease do not have other birth defects. So it tends to occur in association with other anomalies or as part of a unidentified syndrome in nearly 25 to 40% cases. In fact, nearly in 1/3 of the children with chromosomal abnormalities will have congenital heart disease, and something is called as aneuploidy, like the abnormal chromosomal number tends to account for really a huge number of congenital heart disease. So it makes us think, what is the reason? What is the etiology for this? So the etiology is pretty complex, and definitely it is associated with the both the environmental and also the genetic causes. And on a genetic basis, congenital heart disease is actually like a heterogeneous disease. In fact, 55 human disease genes have been identified so far, and a lot more, especially in the animal models of mice. So what happens is, if there's someone with a susceptible allele, okay, so someone may still be carrying a susceptible allele, and of course, there will be someone else who will be having a normal heart. However, there will be someone who is going to develop the congenital heart disease, having genetic variants, epigenetic factors, environmental factors, and also the hemodynamic factors as well. So that's why this concept is very important. So there are various syndromes which does happen due to the aneuploidy and microdeletions. For example, the trisomy 13, which is the most common one, I would say, like among the most common ones. So which has ASD, VSD, PDA as well. So similarly, like trisomy 18. So other than the above subsets, I said it, they will be having TOF or these other variants as well, which can be seen in like 90 to 100% of the congenital heart disease. Similarly, the other rare variants, I would say, like trisomy 21 or the Turner syndrome. Turner syndrome, I am sure a lot of people may recall, otherwise DGOD syndrome as well. DGOD syndrome is like 22q11.1 deletion, in fact. Okay, so which is associated with the aortic arch anomalies or the truncus arteriosus and all. So this was, as I was telling you, this is due to aneuploidy, okay, and microdeletions. So there are various syndromes as well, which can be associated with the single gene defects, like the Noonan syndrome. Noonan syndrome is the one with pulmonary stenosis and dysplastic pulmonary valve. So with HCM and coarctation of aorta as well. The various genes which is associated is the various genes which is associated with this problem, as we can see, is PTPN11, the KRAS, the SOS1 as well. Then there are many other syndromes as well. And I must say, these are important questions for everyone, which can be asked, like the Costello syndrome, which is associated with pulmonary stenosis with HCM or cardiac conduction abnormalities as well. Then there's like Alagille syndrome or Marfan syndrome or the Holt-Oram syndrome as well. Holt-Oram is the one with atrial septal defect, ventricular septal defect, AVSD, and progressive AV conduction disease as well. So to be able to understand, we should try to understand what is the molecular pathology for these congenital heart disease. So there are various mechanisms, right from the ligands, which goes to the various receptors, due to which we tend to start noticing those downstream effectors, in the form of MAPK1, MAP2K2, NF1, and all these effectors, in fact. And these are the ones which tends to lead and affect the transcription factors in the form of CETA2 or FOXH1 or FOXP1, in fact. And they are the ones which are going to affect those genes. And after those genes are the ones which will be leading to different defective histone modifications. So it's quite a lot of thing, but if you really want to understand the mechanism, it really is important. So there are various genes which is associated with the congenital heart disease, like the genes which are encoding the transcription factors, otherwise the genes involved in the cell signaling, otherwise the genes encoding the structural proteins, and also the genes encoding epigenetic regulators as well. So there are a lot of non-syndromic congenital heart disease which is associated with single gene defects. For example, the one gene with NKX2-5, that is the one which is associated with atrial septal defect, otherwise the atrioventricular conduction delay, or the TOF, or also the tricuspid valve abnormalities. Similarly, if someone's GATA4 is affected, so the patient will be having atrial septal defect or the ventricular septal defect. Similarly, if someone has been getting affected with the BMPR2, so those patients are the ones who will be having cardiac septation defects associated with pulmonary hypertension. Similarly, if someone is getting affected with Notch1, then the patient is going to have a bicuspid aortic valve and our early valve calcification. And the one with PROSID 240, they are the ones with TGA defects which are going to happen. So there has been a wonderful paper, I would say, earlier. So it was the Danish registry, which tried to focus on like almost quarter short of 1 million people in Denmark, and they included those patients from 1977 to 2005. So in that, the author Nina et al., they tried to see on the recurrence of congenital heart defects in the families. And it was a beautiful paper published in Circulation 2019, 9. And I would really like you all to go through that. So in that, they tried to see for the heart defects in the first degree relatives in the form of like heterotaxy, conotruncal defects, septal defects, isolated AVSD, LV outflow defect, RV outflow defect as well. And yeah, the number of congenital heart disease, as we can see, so it is of course associated with relative risk and also the 95% confidence interval. So if we'll try to see, these intervals are some of the highest ones associated with heterotaxy and the RV outflow tract obstruction as well. So when they further try to see how about those people who all are twins or of the same sex, so they could notice like, yeah, the incidence is seen in like nearly 170 congenital heart disease with a relative risk of 12.5. The highest one was seen actually like in first degree relatives. So the first degree relatives are the ones who will be having a really, really high risk of the congenital heart disease. So even if there are twins or same sex or unlike sex, it may be different. So the most common patients who will be having congenital heart disease is, of course, the first degree relative, then comes the second degree relative, and then comes the third degree relative. Is it okay? So this is a very important thing, in fact. And so this further emphasizes that indeed, many congenital heart diseases, they tend to run in families. And with advances in genetics, we have been able to find like some of the genetic causes of familial congenital heart diseases, and also the knowledge of familial contribution to congenital heart disease of an individual or population level is of course sparse. So can anyone recall what are those possible reasons for these, or otherwise anyone can recall about the role of VEGF in familial congenital heart disease? Let me try to summarize it for you. VEGF is vascular endothelial growth factor. So first thing to understand is, what is its role actually? VEGF. What is the role of VEGF actually? So the VEGF is the one which plays a critical role. Okay, so is there some chats? No, okay. So what happens is VEGF is the one which has a critical role, especially in the formation of endocardial cushions during the heart development, especially in the mouse model. Okay, so there are three promoters of the VEGF, namely which is called as the C2578A, G1154A, and C634G, and they have been shown to be modifier of deletion syndrome. Okay, so what happens is in the family-based study, the low expression of VEGF halotype was transmitted more often to affected children, suggesting that it may play a role in the development of isolated TOF patients, in fact. So there's a lot of newer data as well, which is coming up, which does show that, yeah, it may not really play a significant role. And in fact, when they tried to see a paper by Giffen et al., came in like 2009, so the genotyped 771 congenital heart disease cases, of which nearly 600 patients had TOF, and carried out case control analysis using haplotype tagging SNPs in VEGF. And common or rare genetic variations in VEGF does not significantly predispose to the risk of TOF. So this is another really important paper in which they try to study about the strong association about the MTHFR and the congenital heart disease. So yes, data has been there everywhere, I would say as well. However, in the large study, when they try to analyze the genotyping data from nearly like 6,000 patients, and with like around 10,000 controls, and they further did a lot of meta-analysis as well of nearly 2,000 patients, they did find that there's no significant effect at all on the congenital heart disease. These are like very important MCQs and all. So if you're trying to appear for the further MRCP exams or any of these exams and all, no, in future, the board exams, they will be very important questions. So like the MTHFR, similarly, there is GAT-A4 as well. So GATA, it is called as. GATA is a family of transcription factors, an upstream regulator of genes expressed during the embryogenesis and cardiac morphogenesis. So JAT-A4 and familial TOF, so there is 3 novel heterozygous mutations of GAT-A4, okay, which has been identified especially in those families of TOF. And in each family, the mutant allele was present in all the affected family members, but absent in the unaffected. So definitely there seems like a pretty higher association. And the family, if there is a family history of any heart defect, among the first 3 degree relatives, in fact, then in the population, definitely 2 to 5% heart defects will be seen in the population as well. And the same heart defect phenotype shows strong familial clustering with the relative risks of recurrence of 3-fold to 80-fold in the first degree relatives. And there are very few candidate genes which has been systematically investigated to any possible contribution of common variants to disease risk. And yes, there is limited data, if any, on identification of culprit genes through the whole genome sequence on familial congenital heart disease as well. So as you can see, these are the electrical conduction system of the heart and the coronary artery vessels through which the blood supply happens to the different areas of the heart. However, with passage of time and year, we may notice the patients developing cardiomyopathy. So in the cardiomyopathy, there are different types: the hypertrophic cardiomyopathy, the dilated cardiomyopathy, restrictive cardiomyopathy, the arrhythmogenic right ventricular cardiomyopathy, or, okay. So these cardiomyopathies initially were thought of like, yeah, they are asymptomatic. Nothing can be done, or like rather asymptomatic, I would say idiopathic. Idiopathic means they didn't mention about the causes or what is the possible etiology for that. Okay. Can anyone recall about the hypertrophic cardiomyopathy? How much should be the level of obstruction, or how do you define that? Come on, don't disappoint me. So my question is very simple. How do you identify a hypertrophic cardiomyopathy?
There will be left ventricular enlargement, sir.
Okay, enlargement, okay, and come on, I expect better answers from you guys. Being a program chair, now I'm feeling a bit ashamed when I'm hearing answers like this. Now I'm a program chair of you guys since more than 5 years of this program, but this is pretty disappointing for me. I can already hear someone turning pages. So, how do you diagnose them? So, diagnosis can be done by echo, cardiac catheterization, or even the cardiac MRI, or with the ECG as well. Okay. So sometimes, if someone is really good in clinical, one can even what is called as pulsus dysvariance. You should try to read about it in detail. Even during uh, the cardiac catheterization, one can see Brukenberg brown wall marrow sign. I'm not going to teach them in detail right now because this is not my topic right now. Okay, but you should read about it and you should keep it in the mind as well. In fact, echo is a really good one, or otherwise cardiac MRI, we call it as a gold standard for this. And of course, the genetics also tends to have a very important role. Okay, anyways, uh, so what happens is the main thing what we are always bothered is the if there is associated unexplained left ventricular hypertrophy, and the incidence wise it is like 1 in 500. So what happens is if you come across a patient like this, what is the differential diagnosis you will think? Always try to rule out hypertension, aortic stenosis, or even the physiologic hypertrophy. So if someone is a highly trained athlete, you should try to rule it out as well. Okay. And then after that, you have done, so there can be monogenic disorder, which is a dominant trait, and the mutations in genes that encode the protein components of cardiac sarcomere. In fact, the penetrance is incomplete and lowest at very young ages, which often displays or delays the clinical diagnosis until adolescence or even adulthood as well. Can anyone recall the various genes? So there are 8 genes which is responsible for this. So like the beta myosin heavy chain, alpha tropomyosin, cardiac troponin T, the cardiac myosin binding protein C, myosin regulatory light chain, MYL2, or the myosin essential light chain, which is my MYL3, or the cardiac troponin E, TNNI3, or even the cardiac alpha actin, which is said as the ACTC1. Is it okay? So, so when they try to see that, they could see that, yeah, it is not associated with any mutation in like 40 to 60%. However, there are these different genes which I mentioned, which can be associated with various of these patients. So MYH7 is the one which is associated in like nearly 20% of these patients. So it can be pretty common. But it's not as easy as well. Always like, okay, there is a patient, there is this disease. Okay, let's do the genetic testing. So what happens is in the genetic heterogeneity. So, for example, distinct genes which causes the same disease as well. There can be allelic variations, like the distinct mutations in the same gene. Similarly, the morphological phenotypes and disease severity can also affect the background genomic variation, lifestyle, and also the exposures are other contributory factors. So yes, there are some benefits, but also has its own limitations as well. Benefits in the sense like, okay, they can confirm in the ambiguous cases and before any overt hypertrophy. But yeah, there's limited positive predictive value as well. And yes, it can rule out the non-effective cases. Similarly, but yeah, in the absence of a known mutation or a negative test, doesn't rule out SCM. Similarly, if it can also further help, for example, for the prenatal and pre-implantation diagnosis. However, there's limited clinical and prognostic contribution. So that's why a test should not be just done for the sake of testing. So we also have to understand what is called as a genotype phenotype correlation, because these are the ones which can be important for modifying the genetic, epigenetic, and environmental factors. And the MYH7 is the one which is associated with increased risk for sudden cardiac death. And the one like MYBPC3 mutations, they tend to present later in life, okay, and displays less morbidity and lower penetrance. So I'm sure you all will be aware of various storage and metabolic cardiomyopathies, okay, like the PRK, G2 mutations, GLE or LAMP2 mutations as well. So which is associated with alpha galactosidase or the lysosome associated membrane protein to inheritance, in fact. And that's why they tend to develop the glycogen disease or the lysosomal remnant disease as well. So what can be done if you have a patient of all these mutations? What are you going to do? So if there is someone with a PRKG2 cardiomyopathy, then you must monitor them because of the high incidence of the conduction defects. However, if there is someone with LAMP2 mutations, then it does definitely require early cardiac transplant. Similarly, if there is someone with GLA mutations, what is called as the Fabry disease, we must treat them with enzyme replacement therapy. Okay, so how about those other cardiomyopathy? For example, the dilated cardiomyopathy. So if you all will recall, there's a ventricular chamber enlargement of the systolic function, and 50% of non-ischemic dilated cardiomyopathy has no identifiable etiology, and the genetic causes are increasingly identified. And the prevalence of unexplained dilated cardiomyopathy is at like 1 is to 2,500 in fact. So the genes which is involved in the force generation, the force transmission, sarcomere integrity, cytoskeletal and nuclear architecture, or the electrolyte homeostasis, or even the mitochondrial function and transcriptions are the ones which get affected. And mostly these are autosomal dominant. So there are some few autosomal recessive as well. It can be age dependent, and it is associated with genetic heterogeneity as well. And there is low sensitivity for detection of pathogenic mutations. So if we look carefully at the mechanism, what we will notice that it's pretty complex, and as I had said, it's all really on the cellular level, about which I had given a brief overview earlier. The genes which is are getting involved even in the cardiomyopathies as well, there is now better clinical management which is available, because they are able to eliminate the ambiguities which is associated with phenotypic variations, that is, mild ventricular remodeling in a competitive athlete, And we can guide the use of emerging therapies that tend to target the biophysical consequences association with the mutations. Okay, and the cost-effective screening of the first-degree family relatives also tends to eliminate the healthcare expenditure for relatives without pathogenic mutations. Similarly, the family screening, which is important with children and adolescents, which may not yet have manifest clinical feature of disease, but may be at risk for sudden death. So just doing the test is not enough. So the interpretation of the test is also important. Interpreting in the sense of like to identify the definitive pathogenic mutations or even the identification of a probable pathogenic mutations, but also additional evidence, for example, like a familial co-segregation or confirmatory data in unrelated affected patients is necessary, and identification of a variant of unknown significance. So yes, specificity is low. Overall accuracy is only like 65 to 80% for predicting the pathogenicity. So that's why the genotypic, as we can see that genotype positive, genotype, phenotype negative individual are also present. So for them, what you can do is just do a clinical screening. Most often these patients are pretty young, and yes, they can be complex uh, to manage. And the longitudinal study of genotype positive, phenotype negative individuals tends to provide the unique opportunity to study the natural history of disease, including the phenotype conversion. This is again a beautiful chart which shows right from the clinical screening how they should be screened, for what parameters they should be screened as well. For example, HCM, you will start noticing in the early childhood there will be family history of sudden cardiac death. Actually, you may notice some of those symptoms as well, and also in adolescence, in fact. Similarly, the dilated cardiomyopathy, like every later on, like you should screen them later on, every 1 to 2 years in childhood or even in adulthood as well. And once the symptoms has onset has been there, like at least every 3 to 5 years, there is the genetic screening, as I had said, it is very important. But what happens is you must follow the guidelines. So the guidelines is like they will guide you to the like point of if you are able to identify, okay, management, you must do the management which I said it. However, if you're not able to do identify the etiology, you should keep on what is called as clinical screening. You should keep on looking out as well. And yes, if there's complete negative mutation, yes, you can say it like that. Okay, they can be discharged from such clinics. So that's why it is very important. Then comes the chromosomal anomalies. Chromosomal anomalies in the sense, so what happens is like nearly 80% of the trisomy 13 are the ones who tend to have chromosomal anomalies. Similarly, nearly half of those patients with trisomy 21 tend to have congenital heart disease. However, if there's a patient of trisomy 18, all of them will have. In fact, if there is a Turner, so if there's a Turner patient, and, and 1/3 of the female patients will tend to have the congenital heart disease. Similarly, if there is a patient of Klinefelter syndrome, okay, with XXY, so they will be having 50% congenital heart disease. DiGeorge as well. DiGeorge syndrome is the one associated with dysmorphic facies. Similarly, then comes the Williams-Buren syndrome as well. Similarly, then, as I had already said it, there are single gene mutations as well, which is associated with such diseases, which we all have to be really careful for, like Marfan syndrome, the Holt-Oram syndrome, the heterotaxy syndrome, the Carr syndrome, or the CHARS syndrome as well. And yeah, whenever we come across these cardiac anomalies, we must try to look out for the associated genes, which is which could be leading to such diseases as well. And this is very, very important to be, as I had already shared earlier. So, for example, how prevalent is it in, for example, the first degree relative, the second degree relative, or even the third degree relative as well? Then the fetal genetics. Fetal genetics is, why is it important in the sense? Because what happens is these are the cells which is obtained from amniotic fluid or the chorionic villus biopsy. And the fetuses in whom the congenital heart disease uh, genetic testing can be done, in fact. And the fetal echocardiography can be indicated whenever a chromosomal abnormality is diagnosed due to any other possible reason. Okay, so then the next modality is familial hypercholesterolemia. So it can happen in like 1 in 500 patients, and in which we have to identify the pathogenic mutations in probands, which is of utmost importance in pediatric and adolescent family members, in which the clinical criteria may not be well defined. So they also tend to have the autosomal transmission. So what is going to happen is, due to the mutations, it is going to affect the LDL receptors, due to which there will be uh, a higher level of LDL cholesterol. So if there will be higher level of cholesterol, so there will be more atherosclerosis, and that is the one which is going to lead to myocardial infarction, angina, or those clinical problems as well. So can anyone recall what is phytosterolemia? So phytosterols, does it ring a bell? Anyone? Let me see. No. Why no, Anupa? Why is it no? You all should be better prepared for the topic. Huh? Topics are well set in advance and you guys are not even prepared. So what is phytosterolemia? So actually this is due to the abnormal absorption of sterols, especially those of the plant origin. And they are the ones also which lead to the same thing, premature coronary atherosclerosis. It can be associated with hemolytic anemia or liver disease, in fact, as well. So this is the one which tries to show some of those different mechanisms, what has been happening. So for example, if you will see in the lumen or in the enterocyte or even in the lymphatic system as well. So that is how the overall, the problems will be happening. There are also various genes which can be associated with triglyceride metabolism alterations, like the ones affecting the apolipoproteins or the LPL or even the ApoA5 gene variants as well. So similarly, HDL cholesterol levels can also be getting affected by the LCAT gene, leading to fish eye disease. Otherwise, the ABCA1 gene Tangier disease, okay, which is again autosomal recessive. Then similarly, the familial alpha lipoproteinemia, which is again a autosomal disease. Dominant, I would say, sorry. So then statin-induced myopathy. Statin-induced myopathy, if one will recall, whenever we are putting or someone or starting on this, we may come across this problem as well. But yes, it can happen in like 1 to 10%, but there's also a genetic mechanism for these things. So some of those patients can also be having the heritable pulmonary arterial hypertension. So it has been documented, like we have to start thinking like whenever the pulmonary arterial hypertension is documented in 2 or more individuals, and if there is associated with a mutation in a gene. So the strange thing about this disease is like there's no associated or known family history. Okay, and the mutations in the morphogenic protein receptor type 2 can be autosomal dominant, so which leads to reduced penetrance, variable expressivity, and there can be female predominance. Genetic, genomic, and other factors can modify the disease expression as well. Okay. So now, how about the channelopathies? Channelopathies are very important to understand because they can be significantly associated with a sudden cardiac death. So what happens is, uh, even of those patients of sudden cardiac death, 5 to 15% cannot have any structural abnormality at autopsy, in fact. So initially they were thought of like, okay, it is idiopathic, but now there are a lot of genetic causes as well, which has been pointed out in such diseases. So if one will recall the action potential mechanism starting from the different phases and the ECG going through various polarizations, depolarizations, and repolarizations as well. So there's a lot of these channels which is associated like right from the beginning, like the HCN4, and then there are HERG or potassium channels, which we can see it as well. So these are the ones which lead to various channelopathies. So one of them, pretty common one, is called as the long QT syndrome. So this is the one which is isolated or with the extracardiac manifestations. Why is it so? Because what happens is there are various problems like extracardiac manifestations, like the GLJ, or even the Long-Nielsen syndrome as well, okay, which can be associated with the congenital deafness. Okay, and then there is also the Anderson-Towle syndrome. Anderson-Towle syndrome, if you will remember, these are the patients which are associated with hypokalemic periodic paralysis. And on a overall basis, one may also notice facial dysmorphism, in fact. Someone may also be having a Timothy syndrome, in which one can notice syndactyly or the developmental disorders or even autism as well. So this is a great list, I would say, for all of you to refer to. So for example, the long QT syndrome can be of different types, like 1, 2, 3, 4 to 13, in fact. So the important thing to know is like, how about the 1? So the 1 is associated with KCNQ1. Even the one the long QT syndrome 3 is also very important, because this is the one which gets affected in with the SCN5A. Okay. And the one at 13, it is due to loss of KCNJ5. So they can be important MCQs again as well to you all, that which one is associated with which type, and is it a gain function, is it a loss of function, and which is the associated channel as well. So this can be something really important as well. Okay, so among these, the most common ones, which is, as you can already seen over here, is try to make a figure in your mind. Okay, it will really help you recall, or for easy recall of these things, because it can be confusing to anyone, in fact. So the type 1 is the one associated with exercise or swimming. Okay. Second one is associated with loud noise or sudden awakening. And the long QT3 is the one which is associated with sleep. The patient will be having problems during bigger things. So one is exercise or swimming. Second one is loud noise or sudden awakening. And the last one, the LQT3, is the one which is associated with sleep. Being a physician, important thing to recall is 1 and 2 will definitely respond good to the beta blockers, but 3 may not respond to the beta blocker. Okay? So what may happen is during all these 3, there's incomplete penetrance. So genetic testing can be used to guide the management of mutation or even for the risk stratification. In fact, each of these genetic variants has a typical trigger for arrhythmic events and a variable response to beta blockers. So there are various other channelopathies as well, like the short QT syndrome. Okay, and there's also Brugada syndrome as well. Brugada syndrome is the one with SCN5A, and there are also like catecholaminergic polymorphic, which can be associated with ryanodine receptors.
PDF
Yes, Dr. Monica, can you please mute your microphone? Thank you. So, why are we interested so much in the Brugada syndrome? Brugada syndrome, because it can literally lead to death when someone is having either at rest or even during fever, or if someone has had a meal and then there's a history of sudden cardiac death. So one may notice that. And as I already said, it is associated with loss of function mutation of SCN5A, or the CAC-NA1C, or CAC-NB2. And in fact, there's no more than 30% positive for disease-causing mutations. And in fact, the genetic testing cannot guide the therapeutic decisions, and they are mostly limited to family screening. Then comes the short QT syndrome. That is the one which is in which the mutation is noted in 6 genes and still account, not often, but definitely a few, we would say. So far, no single gene has been accounted, in fact, and yes, the role of genetic testing as well for such kind of patients is very limited. Then how about the CPVT? CPVT we all come across as well. And yeah, the strange thing is like, it has been although associated with mutations of ryanodine receptors and calciquatrin. And yeah, genetic genotyping screening must be applied to these kind of family members as well to have a look out for the problem. And also, whenever if some mutations has already been identified for such patients, beta blockers must be given to such kind of patients as well. So there are some other diseases like the sick sinus syndrome or the cardiac conduction disease or even the familial atrial fibrillation as well. So for these patients, it is always nice to be able to identify these genes as well. As I said it, so the mechanism, what happens is, after one is aware of the possible mechanism, then the treatment, I would say, is becomes relatively much more easier once you know the real mechanism. So that's why you have to try to study the genetic variations that tend to influence the individual's response to drugs. And also, the more personalized approaches can be taken and considered for fewer side effects. So there is utility, of course, of the genetic testing, for example, using the pharmacogenomic medicine response profiles, and you try to test for the genes, the metabolism, or even the action, okay, or the because you are trying to give them an optical medicine therapy so that you can not only reduce the risk, but also help them on the various parameters of ethical, legal, or social implications as well. So if you will know that Yeah, there are different types of patients. So if someone is having a gene problem, okay, it is going to affect the protein and further, of course, the metabolite as well. And you know the response. So on the basis of which there will be a normal drug metabolism and response with nominal side effects. However, if there is an abnormal aberrant response, there will be heightened drug metabolism and response as well. And of course, they are the ones which will be associated with significant side effects. And this is why when we try to give statins to some of the patients, we may come across variable lipid lowering effect or even the risk of myopathy as well. Similarly, even for whenever we are trying to give anticoagulants as well for some of the patients, dosing problems can be seen. And in fact, it can be quite a lot common as well. So pharmacogenetics, for example, especially of those patients they did try to see in a patient group of ACS, acute coronary syndrome patients, and they could see when they try to test for the CYP2C19 testing that someone may need standard dosing of clopidogrel and someone with the prasugrel, okay? But may respond differently to these drugs as well. And what is the reason for that is because these different genes, which is of course on the different locations as well, their functions are pretty different as well. And that is why when we are trying to see for their effect on even on anticoagulation as well. So for example, CYP2C9 gene will lead to increased sensitivity, okay? However, the other one tends to affect the interaction of vitamin K with the clotting factors. So that's why sometimes when we are not getting adequate response even to anticoagulation, we may think of these genes as well. So there is a good genetic role for the interaction of these anticoagulants as well. So for the vitamin K antagonist, dosage is difficult to predict and frequent monitoring is indeed necessary as well. So after going through all those things, so one important question for you guys. We are giving a NOAC, okay, to a group of patients. They are diabetics, yeah? So some patients need they are insulin dependent. Some are non-insulin dependent, okay? Some are taking oral anti-diabetic medications. So as I said it, a group is taking insulin, another group is taking oral hypoglycemic, another is taking injectable hypoglycemic, okay? And these patients are being treated with NOACs for the AF, for example, like the dabigatran, rivaroxaban and all. So for which group of patients, there will be no therapeutic effect at all.